Hello, can you all hear me? I think there is an echo though. It's okay. Okay, so good evening and welcome everyone. My name is Marwa Farag. I'm an associate professor here at the Doha Institute at the School of Public Administration and Development Economics and a member of the Center for Conflict and Humanitarian Studies. And on behalf of the director of the center, Dr. Sultan Barakat, and my colleagues, we would like to welcome you to the center. So the center is an interdisciplinary research and study center, which explains why someone like me with background in health policy and health economics is part of the center. And the center's research really focuses on studying the causes, impact, and responses to conflict and emergencies in the region, so in the Middle East and North Africa region. So today's event is part of our outreach activities, and we're very happy because today is April 7 marks World Health Day. So we are very pleased to be hosting the 124th Global Health History Seminar here at the Doha Institute. And this seminar series was started in 2004. And the seminar is co-hosted and co-organized by the World Health Organization and the Center for Global Health Histories at the University of York, headed by Professor Sanjoy Bhattacharya, who is here with us today and will tell us a little bit more about the center and the seminar series.
So, assalamu alaikum, dear friends and colleagues. It's an absolute honor to be at the Center for Conflict and Humanitarian Studies at the Doha Institute and working with partners at WHO Eastern Mediterranean Regional Office and supported by partners from WHO Europe. So for me, as a historian, I realize this is a historic moment because this is the first WHO Global Health History Seminar in the region outside the WHO EMRO offices. And an unexpected pleasure, it's not even scripted, so I have to say that an age-old collaborator, Dr. Zafar Mirza, happened to be in Doha and he has joined us today. And we are very grateful for his support. I mean, he and I have been working on this since 2004, one of the earliest allies in this initiative. The WHO Global Health Histories Initiative has a mission. And that mission is based on the principle that the understanding of the history of health, especially during the last 60 years, helps the global health community respond to the challenges of today and help shape a healthier future for everyone, especially those most in need. The idea of the Global Health History Seminar is to excavate and record the largest possible range of voices that are involved in national, international, and global health. Often, when we write histories of successes or even failures, we tend to focus on a handful of voices. And often those voices tend to be either in Europe or North America. But as we all know, when health happens in the regions and localities, and I just learned so much in about 10 minutes of attending a class, health projects cannot be implemented unless there's local and national contributions. Global health history since 2004 has been an attempt to uncover, record, and present voices from nations and their localities, so that historians of the future, that is the students I can see, do not ever forget that energies have to be brought together to make successes what they are. We are honored to have the Center for Conflict and Humanitarian Studies run by Professor Sultan Barakat, who I know from the University of York for a very long time, one of my first friends when I arrived in 2010 at York. He was very welcoming, showed me the ropes, as they say, as part of this global partnership. And we would like to thank the Center and the Doha Institute for all its support for this event. And I would like to apologize for the many emails I sent both of you at a busy time. And we as a partnership thank the Wellcome Trust, a global charitable foundation based in the UK, for its support to this event. So thank you so much.
You're very welcome. Thank you so much, Professor Bhattacharya. So the topic of today's seminar is really how we should rethink humanitarian interventions in acute emergencies. And we pose a few more questions about why is it important to reshape the humanitarian system around affected populations, putting them back at the center. Things like whether universal health coverage could be implemented in health emergencies. That's another question we pose. The other question, which is really important also, is what are the interlinkages between humanitarian response and long-term development goals? A really critical question. So to help us answer these questions, we have our distinguished speakers today, whom I will introduce in a minute. Each speaker will speak for about 20 minutes, then we will open it up for questions. So that's the format of today's seminar. So I will introduce the first speaker now. I am honored to present our first speaker, Dr. Awad Mataria. Dr. Mataria is the regional advisor at the Eastern Mediterranean Regional Office, EMRO, of the World Health Organization. He is a pharmacist by training and has a master's in health system analysis from Université de Rennes and a PhD in health economics from the Université de la Méditerranée in Marseille, France. He also did part of his training at the Université de Lyon and at the National School of Public Health. Very French. No. Dr. Mataria's areas of expertise cover research in economic evaluation, healthcare interventions, universal health coverage, social health insurance, using economics in healthcare priority setting, financing and organization of health systems, and national health accounts. So really, he has presented in numerous conferences, and he's extensively published in high-impact peer-reviewed journals such as Health Economics, The Lancet, to name but a few. And I'm very pleased to introduce him to you today. Please, the floor is yours.
Yes. So again, thank you very much. It's an honor to be with you here and to share some of our work in the area of universal health coverage with a focus on health financing issues. So as Marwa has mentioned, my recent function has been to work with the WHO. So I'm based at the regional office for the Eastern Mediterranean, and I'm managing the program of health financing for universal health coverage. Again, it's a privilege to have Dr. Zafar Mirza with us, who has more extensive experience in the area of health systems at large in relation to conflicts and universal health coverage. So when I was asked to make this presentation, I tried to bring in issues related to the theme of the center where we are, and in particular in relation to conflicts and conflict-affected areas. And I would like to share some reflections. Being in a university setting or research institution, these are more or less, some of them are more at a stage of still reflection and to develop ideas about how we could think about health financing issues for universal health coverage in such context. So I structured a presentation to give you an overview of what we mean by universal health coverage, if any of you has not come across this term so far. And then the linkage between universal health coverage and health system strengthening in the context of the Sustainable Development Agenda. Then I will share with you some information about health financing, in particular in the context of our region, the Eastern Mediterranean region. And then I'll share some information about health financing in the context of emergencies and what type of challenges countries become faced with when emergency or conflicts erupt. And then I will share with you this reflection about how to think health financing and improving the performance of the health financing systems in context of emergencies, and I will conclude with some general words. So for us at WHO and at the UN level in general, but also for the development agenda, the way that we would like to look at universal health coverage is that it is a situation where all people and all communities have access to their needed healthcare services. And when we talk about healthcare services, it's not only about curative care, we like to present that as a full spectrum, from promotion to prevention to curative care to rehabilitation and even to palliative care. So we would like people to have access to their needed healthcare services, and we would like also those services to be in good quality, meaning that they should be effective enough to respond to the needs of the population and to improve the health of the population and the health of the individuals. And at the same time, when people use these services, we would like them to be financially protected, meaning that they do not need to pay too much to the care that they need, to the extent that they might become poor, or not to spend enough money on other essential commodities, essential services, like not sending their children to school because they have to pay for healthcare, or not eating good food because they have to spend to pay for healthcare. So the way, if we look at universal health coverage from this perspective, we see that it can be defined through 3 dimensions. And those are usually represented using this box or this cube, and we call it the universal health coverage cube. These are the population coverage dimension, the service coverage dimension, and the financial protection dimension. And the way we present it usually by saying that a country is in a situation where part of the population is covered for certain types of services for a part of the cost of those services. And each country can do things, take initiatives to expand that coverage, so that we want to cover more and more people, hopefully everyone, for more and more services, depending on the needs of the population, for more and more of the cost of those services, so that what remains at the charge of individuals do not push them into the impoverishment or into what we call catastrophic expenditure. So to reach there, what we do at WHO is to help countries strengthening their health systems. So the way that we see it is that universal health coverage is what we want, while what we do in countries is health system strengthening. So we would like to strengthen the health systems to move towards universal health coverage, to guarantee what we have discussed as a definition. And there is also a realization that once we reach to that universal health coverage, once we progress towards universal health coverage, we will be able to achieve and progress towards several of the sustainable development goals and the different targets. So amongst those goals, we can see that universal health coverage is very much linked to the equity agenda of the sustainable development goals. So in particular, that goal number 3, which is related to health. But also it's linked with the development agenda of the sustainable development goals, because it allows creating more jobs, more employment in the economy of the country. But also it results also in creating more equity and equality in the system by empowering women, by improving the health of children and others. And another realization is that universal health coverage is also linked with the economic development agenda in the countries. So, and at the same time, another one is related to more protecting against emergencies and against what we call like conflicts or other situations. So the point is that what we want to achieve is universal health coverage. Once we do that, we will be moving towards the different aspects or different domains of the sustainable development agenda, whether it is equity, whether it is efficiency, whether it is economic development. Now, going more deeper into the area that I'm focused on, and my area of specialization, which is health financing. So the way that we look at it from health finance point of view is that countries need to develop their health finance systems to advance on the different dimensions of universal health coverage. And the way that economists have been framing it is through what we call the goals, the ultimate goals of universal health coverage, which are in the definition. So if you look again at the definition, what we try to do basically is to reduce the gap between utilization and need. We want to improve the quality of care, and we want to enhance financial protection. So those we qualify as the final goals of universal health coverage from a health financing point of view. We have some intermediate objectives, which for economists, these are very basic: efficiency, equity, but also we add the agenda of transparency and accountability. But from health financing point of view, the things that we work on are what we call the health financing functions. And these are basically 3. A health financing system in the country needs to work to raise more money for health. Money could come from different sources, could come from taxes, could come from contributions to a certain health insurance program, whether it is mandatory, like a social health insurance, or a voluntary, like a private health insurance. So all of these can bring more money for health. But then the second function is how to manage these resources that are mobilized for health, and this is what we call the pooling function. It is the function that is responsible to mixing those different sources in order to guarantee what we call the cross-subsidization amongst different categories of the population. What we would like is that the contribution of the rich pays for the care of the poor, The contributions of the young and productive people pays for the care of the senior people, of the elderly, and so on. The contribution of the healthy to pay for the cost of care of the sick individual. And that can only happen if we do that pooling function, if we put the money together in a certain basket, like a health insurance fund, like a general government budget, where the money can come from different sources. Once the money is raised and pooled, we start using it to purchase healthcare services, and this is the purchasing function. And under purchasing, oftentimes, when countries talk about health financing, they think about how to raise more money. They might think about how to establish a certain financial protection arrangement, like a health insurance program, but they think less about how to use that money. And under purchasing, we usually try to address 4 questions. We try to see what to purchase, so what benefit package we would like to guarantee for our population, from whom we would like to purchase that. Is it only from the public sector or also from the private sector or the non-governmental sector? For whom you are purchasing these services? Are we talking only about those who are in the formal economy, like those who work for the government or the formal private sector? Or we are also targeting the non-poor, the poor themselves, the vulnerable population, refugees, the migrant population or not? And then the 4th question is how you pay your providers. So this is our framework to think health financing. And when we work with countries, we try to assess their health financing functions based on this framework, and we try to identify options for countries to advance the performance of their health financing systems. Now, last October, we produced this document, which is available on this link if you would like to consult. And it is a document that reviewed the health finance systems in the 22 countries of the Eastern Mediterranean region. So for those who do not know what is exactly the Eastern Mediterranean region, so we have 22 member states, 22 countries, expanding from Morocco to Pakistan. And they are countries of very diverse socioeconomic development, different levels of income. What we have done is that we reviewed the different health finance systems using what we call the elements of the health finance system. So basically, we looked at the macroeconomic situation in the countries. We looked at the health financing system architecture. We looked at the 3 functions: revenue raising, pooling, and purchasing. We looked at the benefit design, what these countries are providing to their population. And we looked at the 3 dimensions of universal health coverage, which I mentioned to you: population coverage, service coverage, and financial protection. And for each country, we have a small chapter, not long enough, but it is enough for policymakers to understand the situation in their own country, or for somebody who wants to have a picture of the different countries in the region. And we supplemented that analytical work with some quantitative data, looking at the time trends in terms of health spending, and we selected indicators that are associated with each of these elements. So you can have a picture how the health finance situation went over time, and we used data for the last 15 years. And we also compared each country with other countries in the region and globally. So there are some time trends and some scatter plot information about each of the countries. So this is available. You can consult it at your leisure time if you are interested. But what we have come up from that analysis are 5 key messages about the region. The first message that we could get from this analysis is that we as a region, we are not investing enough in health. As a region, we have 653 million people living in these 22 countries. We represent almost 9% of the world population. However, in 2015, we spent 153 billion US dollar compared to 7.3 trillion US dollar that the world spent on health. So as a region, we constitute 9% of the world population, but we spend less than 2% of what the world has spent on health in that year. So this is one of the messages that we relay to countries, to policymakers. If I have a chance to meet with the Minister of Finance, which we don't always have that luxury, but this is what we tell them, that we are not allocating enough money for the health sector. Now, why is that happening? This was the second message. This is happening because we are not having enough public expenditure or public investment in the health sector. So if we compare how much is spent from public sources as percentage of GDP in the 22 countries of the region, globally, the average is 3.5% of GDP is spent as public health spending on health. In our region, the average is 2.5%. So we are, Assalamu alaikum, how are you? So we are 1 percentage point less than the global average. And you see there are many countries that are even much lower than that that average. So when we tell countries, you are not really investing enough from your public funding, they say that we don't have money, that our fiscal space, which is the money that is between the hands of the government, is very limited. So we looked into that. When we compare the fiscal space at the regional level with the global level, we found that we are almost at the global average. 35% of the GDP, gross domestic product, is between the hands of the governments in the region as it is globally. So fiscal space is measured by looking at how much is spent by the government on all sectors as percentage of the gross domestic product in the country. And the regional average is 35%, global average is also 35%. And even you see many countries, you have here Djibouti, Kuwait, Oman, Iraq, Qatar, that are having even higher than that average. So, and even doesn't relate to the level of income of the country. You have a low-income country like Djibouti, but a high-income country like Kuwait, Oman, and Qatar, and a middle-income country like Iraq. So the question is not that money is not there. There is money that is available. But so what is happening? What is happening is that there isn't enough prioritization that is given for the health sector. So when we looked at how much is given to health from the government budget, global average is around 11%. Regional average is 9%. We are almost 2 percentage points less than the global average in terms of how much is allocated for the health sector from the government budget. And you have many countries, even high-income countries. Well, it depends. In high-income countries, sometimes the mixture is mixed because of the high GDP in some, inshallah. But also in many others, we are not giving enough the money to the health sector. It's not getting the priority that it needs. The third message that we could get from that analysis is that this is happening in a situation where we do not have enough financial protection arrangements in the countries. Not everyone in the countries of the region is being covered by a certain form of financial protection, whether it is a health insurance program, whether it is government funding that is going for the providers. We find that there are many people in the informal economy, many who are even non-poor, but in the informal sector, who are left behind. We have the poor, the displaced, the refugees in the regions. We have people who are suffering from some conditions that are left behind once they suffer from these conditions because they are too expensive. And at the same time, we find that there are some parts of the populations of the region who have double and triple coverage. So there is this mix of picture that we are not providing enough financial protection to the population of the region. The fourth message is that because of the low public investment, because of the lack of financial protection arrangements in the countries, we find that people have to pay out of their own pocket when they are sick, when they are vulnerable, when they go and demand healthcare services. Unfortunately, for the last 15 years, the share of out-of-pocket payment in the region as percentage of the total health expenditure did not decrease from 40%. It fluctuated around 40% for almost 15 years. Global average is around 30%, but for us, it has been 40% for the last 15 years. And for some countries, it had even reached 70 and 80%. Country where I work now, where I live, Egypt, some numbers mentions that it reaches 80% of the current health expenditure. Afghanistan, we have a colleague I met before from Afghanistan, it's close to 80%. Of course, in the high-income countries in the region, it is lower. In Qatar, our estimation is around 20%. In some countries, less than 20%. But also, we have to take those numbers with a grain of salt because not all countries have done their proper health accounting exercises and did not institutionalize health account exercises. Qatar did two rounds. One of them covered 2 years. Not enough investment because of low public investment in health. And in the lack of financial protection arrangements, we find that there are high level of out-of-pocket payment. What is the consequences of that? The result of that is that we find people having to pay too much for health to the extent that they face what we call financial catastrophe or financial hardship. Under the Sustainable Development Agenda, we have now a target that is related to universal health coverage, and the indicator that is used to measure that target is how much countries, individuals, households, what is the percentage of households that are spending more than 10% of their income or of their total expenditure on health. Globally, we estimate that 800 million people face financial hardship, meaning they are spending more than 10% of their income on health. In our region, 55.5 million people face financial hardship every year, meaning they are spending too much on health out of pocket when they are sick, when they are vulnerable, and when they demand healthcare services. And as a result of that, we estimate 7.7 million people becoming poor every year because of that health expenditure. Globally, the number is 100 million. In our region, 7.7 million people are facing that. So I thought I would give you the picture of the health finance system and the challenges that we are faced with. And now I would like to dig deeper and go a bit more deeper with issues related to emergencies and emergency context. First of all, from a health finance point of view, when we wanted to look at issues related to conflict, post-conflict, emergencies, so we felt that we need to classify emergencies in a way that is operational, that is practical for the purpose of thinking health finance systems and developing health finance systems. And we found that there is a big difference between countries that are affected by acute conflicts or acute emergencies and countries that are affected by chronic emergencies or chronic conflicts. There is a paper in the literature that tried to classify countries based on their level of fragility. And it has used 3 criteria for that level of fragility. It referred to the level of capacity of the government, it referred to the legitimacy of the government, and it referred to the level of security. And these 3 dimensions to qualify a level of fragility in a country are very, very important. So when you look at a situation of acute conflict, like whether there are armed conflicts, there is a political unrest, but also in situation of economic hardship, like having a socio-economic crisis or having a natural disaster in the country, we find that there is low capacity in the government to be able to mobilize, to manage these resources, and to purchase the services. Legitimacy might be challenged at these contexts. There is a big security gap. All of this results in a dysfunctional state, not able to run the health finance system in a certain way. Examples of these, we can see it in Syria, we see it in Yemen, maybe in Libya to some extent, and it depends on the time frame we are looking into. But these are some of the characteristics that one has to take into consideration when you think health financing in context of emergency. Now, if that conflict or that emergency, God forbid, becomes extended, becomes chronic in a way, then there is a prolonged conflict or there is an extended occupation or complex emergency, then in that case, you might find some form of legitimacy being created. In some countries, even in my own country, I come from Palestine, there are elections and there is a government that is formed following election. Many other countries do that, even under conflict situations. So there is some relative legitimacy that might be there. But capacity and security might be still challenged in a certain way. And here I'm trying to relate this to the situation in Afghanistan, but also in Iraq, maybe Libya to some extent, but also Palestine and Somalia. So these are sort of 2 classifications to look at the health finance system. And when we looked deeper, we found that there are some challenges that emerge because of that conflict, whether it is acute or chronic. And I'm listing some of those. I'll just, I would like to share them with you in a certain way. So first, a new challenge that arises in this context is the emergence of refugees and IDPs, internally displaced populations in the countries, who have their own special needs and who have their own, they might have been covered before, but their coverage has been disrupted. 10 days back, we organized a big meeting in Istanbul to try to develop a regional framework to promote the health of migrants and displaced populations. And you find that these category of population, they really need, they have their own needs, and you need to know how to address them. Unfortunately, the cost of care would increase in such context because of that health system is not able to deliver in the way that it used to deliver. Transportation costs would increase the burden on the users, but also the cost on the health system at large. Of course, the public revenues would be challenged in these circumstances because the taxation system might become dysfunctional. The health insurance program, if it had been there, it might become also disrupted and cannot do its work. And health becomes of a reduced priority in the country. So for governments, security becomes higher on the agenda, and they might allocate even less towards health. We see that donors want to come in, and they bring in money, and I was also part briefly of the lecture that Professor Sultan was giving on issues related to donors funding and multi-donor trust fund. So donors come in, but they come with their money and with their challenges, with the problems on how that money can be managed, whether they will comply with what we call the public financial management systems in the country, or they want to create their own parallel channels to disperse their funding. The health finance institutions in the country might become dysfunctional or even destructive in some cases. And this results in an increased hardship. You imagine a situation that people become poorer and they have to pay more out of pocket. Their capacity to pay has decreased. So more people will be faced with financial hardship and out of pocket would become higher and higher. There would be even a lack of capacity to prioritize the limited money that is available. Already we are having limited capacity to know how to use the money that is available. But when in those circumstances, many people would leave the countries, and those who can help in those decisions about allocation in terms to enhance efficiency, technical or allocative efficiency, become less, and then the options that are available become more limited. You might lose health workers who would flee the country, who would be expelled from the country in some circumstances, and those would even exacerbate the shortage of health workforce that we suffer from in the region. And finally, we find that even the information system, which we need to base our decisions to make our prioritization, becomes dysfunctional. We don't collect the right information. We're not able to make decisions based on proper information. So what can we do for health finance systems in these circumstances, keeping in mind the two categories that I presented for you? So what we tried, we organized a consultation on health financing in emergency a year and a half back, and we tried to come up with a vision for health financing in context of emergencies, in context of conflict and post-conflict situation. So what we would like to see is to have a resilient health financing system. And by resilient, we mean that a system that can face the shock, that can absorb it, that can adapt, and that can learn from that shock to become even stronger. So for a situation of acute conflict or emergency, we think that a health finance system becomes resilient if it allows to sustain the delivery of the essential public health functions related to surveillance, related to protection, basic protection. So what we call things in literature, the essential public health function, but also that which would allow an access to what we could qualify as basic health service package, or now we have a term which we use, a priority benefit package in these contexts, but at the same time, we want people to be financially protected. If the conflict becomes, God forbid, chronic and longer in term, or the emergency becomes extended, then maybe the objective or the vision for the health finance system is to guarantee access to an essential health service package, which is larger in scope. Now we use the term of priority benefit package, and we are working on defining one for the region, but also with the financial protection. So if we have those as our visions, then what we have been observing is that from health financing, there are two approaches that countries have been using and development partners have been engaged in, depending on the stage of the emergency. So in some acute conflict situations, we find that the donor community, the international community, might come to substitute for the functions of the state because of the lack of legitimacy, lack of capacity that we referred to. This is an example of Afghanistan, where you find donors contracting out with NGOs sector, non-governmental organization, to deliver on the health service. So they substitute for the function of the government. In a chronic or conflict or in chronic emergency, so we said that there is some sort of legitimacy, there is a functioning somehow government, then the focus could be on building the foundation, building the institutions, strengthening them, and looking at how to move to what we call in health financing strategic purchasing, to make the proper use of the resources in time. I would like to leave you with this framework. So this is work in progress. This is what I refer to as work in progress. I will not go into the details of it, but what we have been working on, and I'll leave you with that slide, is that what could be the objectives that we want to go for in that two contexts, acute and chronic emergencies. And we have identified goals for that regard, for that matter. So for instance, what we want is to leave no one behind. We want everyone to be financially protected. We want to guarantee equity in access. We want to guarantee the financial protection. And what we try to identify are some strategies that are relevant for the acute conflict, but also for the chronic conflict. I can go over those in the discussion if you would like that. And we have some specific objectives that one can look into. But what I want to conclude with is something that we have worked on. Sorry, it is covering, okay. Something that we have worked on recently, which we call the Framework for Action on Advancing Universal Health Coverage in the region. And we try to identify actions for countries to progress on the 3 dimensions of universal health coverage. One of those is related to health financing. And here are the actions that we propose for countries to enhance the performance of their health finance systems. You will have the slide, but these are specific actions for which we recommend to countries to move ahead with. And finally, We have produced this document to help countries developing their health finances strategies to move towards universal health coverage. And we try to identify what we call guiding principles. We have 14 of those that are related to the 3 functions of health financing, which are things that countries need to bear in mind when they want to develop their health finance system to move towards the goal of universal health coverage. Like one of the guiding principles, you need to rely more on public funding. One of the guiding principles, you need to avoid fragmentation. One of the guiding principles, you need to move towards strategic purchasing, and so on, so forth. This is where we are. This is the work that we are doing with countries to analyze their health finance system and to help them developing their health finance strategies, addressing the normal situation, but also the abnormal situation resulting from conflicts and post-conflict circumstances. Thank you very much.
Thank you very much, Dr. Mataria, for giving us a clear picture about health financing in the region and the particular challenges facing countries in conflict situations. So that was, and thank you for the great work that WHO always does in this area. So now I would like to present our second speaker. It gives me great pleasure to present Mr. Monishankar Prasad, who is a writer and a researcher based in the GCC region. He holds a master's degree in environmental engineering from the National University of Singapore and has also studied at the School of Sociology at Nanyang Technological University. He is a prolific contributor in academic conferences as he presented in 6 countries on issues ranging from technology policies to sociolinguistics. Previously, Mr. Prasad has published in journals such as the New Indian Express and Huffington Post, to name but a few. He has also been a panelist for Al Jazeera International and BBC World Panel Discussion and has been interviewed by journals such as Forbes and The Guardian on the emerging issues of the day. He has worked as a sustainability consultant for Fortune 500 companies, public sector clients, startups, and nonprofits in Singapore, Oman, South Sudan, and India. He specializes in social impact assessment for civil, wind, and renewable infrastructure projects. Thank you very much, and please take the floor.
Well, am I audible?
Yes.
Yeah. Okay. Well, from the macro which Dr. Awad started over here, I would like to shift the frame a bit. The frame is of a population which is often not heard. The framing is of a population which is extremely precarious, and they have very, very limited access to resources. So as we are talking about emergencies over here, one is emergencies which happen in the framework of a conflict. But migrant workers, with whom I have extensively worked in Singapore, Oman, Malaysia, to name a few countries, because I'm a second-generation migrant myself. I grew up in Oman. My father was a migrant, I'm a migrant. But we still hold our home passports, essentially. So this topic is very close to my heart, but I also do very rigorous academic work in this area. So I would like to start this conversation. It's not really a talk, and I'm not really a bureaucrat over here. I'm a researcher, and I'm here to inform and engage and provide some evidence. So I would like to start my talk by sharing with you a small poem by a Bangladeshi migrant worker in Singapore who is extremely well published. His name is Mohar Khan. He's a friend of mine. He's just educated till 8th grade, but has a heart and soul of gold. And his little poem, I will speak it in Bangla first and then translate it in English. Rate ashi, rate jai, makan papere khabar khai. In English it is, I come and go, as silently as a night, on pieces of makan paper, my labor takes flight. Which essentially means, which essentially means, makan paper in Singapore and Malaysia is the is a plastic paper on which migrant laborers eat food. So, rate ashe, rate jai. Migrant workers in Singapore, Malaysia, even in Dubai, in Muscat, wherever I worked, they start very early in the morning, around the prayers in the morning. They work 12-hour shifts. Mostly they work overtime. So by the time they come back to their dormitories, as in Singapore and Malaysia, and in this part of the world, they are called camps in this part of the world. They really don't see any sunlight, honestly speaking. And they work 6 days a week, 7 days a week. And essentially, they eat extremely substandard food in most situations, and which affect their health. So when we are talking about emergencies over here, their entire life is an emergency. They're trying to navigate an emergency in a very, very personal frame. So I would like to state, by starting from this poem, what migrant construction workers and also workers who work in various sorts in homes, as house cleaners and everybody, how they actually build resilience, both financially, health-wise, how do they send money back home, and how do they actually work through the system where there is no system at all. So the problem. Health access for migrant workers is extremely intertwined with the materiality, their access to resources, and in turn, their access to resources becomes a social capital in order to engage with the structures when they have these emergencies. A bit of a backstory how migrant workers actually come from Bangladesh, India, Sri Lanka, to Southeast Asia, and also this part of the world. How do they actually come? Most of them come from, they don't come from extremely poor families, they come from low middle class families normally. So what I've conceptually framed as, they are margins in India, they're margins in Bangladesh, but they also become marginal in their in the countries where they work. So it is an M2M model. Margins to margins. The only difference is most of them are middle class in India and Bangladesh. They become extremely poor when they come over here. It's actually a misnomer that they earn a lot of money and bring it back home. They are actually selling off land, jewelry, and they're mortgaging stuff. They are actually bringing whatever their family and their uncles, aunts have earned in order to invest for a better life. So when they come, like it is approximately 15,000 Singapore dollars for a Bangladeshi migrant from Dhaka to come to Singapore, or slightly cheaper to Kuala Lumpur. And it's all ethnographic work done. It's all field notes have been rigorously taken. I've worked about 6 years now. So I have all the statistics and the data with me. So it's about $15,000 which they spend. It takes a very long time for them to navigate the system, pay for passports, actually engage agents, and actually come through to the recipient countries. When they come to the recipient countries, they realize that they don't know the language. So the day when they land up in the airport, it's an emergency. They do not understand the language. Language is a socio-cultural resource in order to navigate the structures. It might not be very, very conventional policy literature, but if you do not know the language, you can't talk to the immigration officer. If you do not know the language, you can't talk to your nurse, your doctor. So where is healthcare access? Where is the healthcare access? So So the entire life becomes a very, very uncertain and messy cycle. When I mean by messy cycle, first of all, the migrant worker has sold off the land, the jewelry, to fund this entire trip. For example, I have excellent Bangladeshi Rohingya friends all over the region, honestly speaking. Malaysia, Singapore, Indonesia, this part of the world. Many of the Rohingya refugees were being persecuted heavily. They cross over to Teknaf, Cox's Bazar. They pay money, somehow manage a Bangladeshi passport. What do they do with the Bangladeshi passport? They contact an agent in this part of the world or in Malaysia, if they're rich enough. If they're slightly more desperate, they take the human trafficking route. And you will not have statistics for this because it's all ethnographic. Statistics are not there because many of these, because Rohingyas speak Bangla at the end of the day. They speak a particular variation of Bangla, which is spoken in Chadga on the border with Burma. But they are essentially refugees. And they fly to this part of the world. They fly to anywhere, they travel to anywhere where they can manage a living. So we were talking about conflict situations. This entire transnational network of migration starts off in a conflict. It starts in a conflict. The conflict is of a historical nature, like in Myanmar, but it might not be a severe conflict, but especially in South India, where many people come to this part of the world from South India to work. Due to the economic situation, due to the realities of the politics, they lose lands. They're not able to study further. And if you ask most of the migrant workers in this part of the world, did your father work here? Has your uncle worked here? Was your mother or your aunt was a maid here? 9 times out of 10, they are all second generation. Because whatever money their parents made here in the boom days of the Gulf, they built a house, but the money runs out, ultimately. They don't have any skills. They were able to earn money because they were painters, they were drivers, they were working as masons in construction sectors, they were doing civil work. But eventually when they went back, because they did not invest, that the financial literacy plays a humongous role over here. They did not invest it properly. They did not buy a house. They are not educated enough. Somebody swindled them money. So what do the children do? They stop their education. They stop college. They take the same route which their parents took 20 years back. And they come back to this part of the world in order to do the same intergenerational stuff. In order to do the same intergenerational stuff which they are doing. So it's a tragic, vicious cycle, but it's an emergency. And how does it relate to healthcare outcomes? It relates to healthcare outcomes because, first of all, they are in a cycle of debt. The death is triggered by poverty. When they come here, they don't know the language. They can't spend on fruits, and they can't spend on food because they don't have enough resources. When they're injured, all that they do is to speak to the local pharmacy in Urdu, Bangla, Tamil, Malayalam, whatever the local language is that, matlab humko Panadol de do. Please provide me a Panadol, as if Panadol is a panacea for all healthcare. So that's all is spoken about. And that's why I call this region the Panadol region. For everything, there's Panadol. So, so even for me, who has worked in engineering, who has worked in consulting, who does a fair degree of research, in Oman, where I grew up, private sector insurance for employees is optional. It is not linked to your visa. It is optional. So after the oil price crash in 2015, when oil prices went from 120 to 30, now to 65 or 70, what small and medium enterprises did in Oman is to remove the healthcare insurance coverage for expatriate employees like me. Okay, I'm an expatriate even after 30 years, but I'm an expat on paper. So they removed it. So the consequence was that when I spoke to my peers, they had families and children. They were extremely scared to drive outside. What if I hit an accident? Who will pay for my medical bills? Many of them, thanks to the economic situation in the Gulf, they have not been paid for 4 months, 5 months, 6 months. So where does the money come from? So again, healthcare outcomes is not only extremely structural, but it is very personal, is extremely political. So whether it's politics with a big P or a small p, it impacts outcomes. So for an engineer such as me, I had to think rather, it's past tense now, fortunately, alhamdulillah. I had to think whether to head on a hiking trip or not, because in case I sprain my ankle, who will pay for my treatment? So it impacts the quality of life as well. And one more thing about migrant workers in Singapore. There are about 1 million of them out of a country of 6 million people. They build everything from marina-based signs to your metros. They take care of the children. They water your beautifully landscaped and manicured spaces. But in 2008, migrant workers were taken out of the public health system in Singapore. Unless you had an insurance law, honestly speaking. So what happened is every injured worker is a ticking bomb. So in case a worker falls off from working at height, what does the worker do? Normally they work for the small construction firms, contractors. So these bosses don't even have enough money to pay for the insurance. So in case they meet an issue, where are they exactly? They fall between the cracks. So the problem is that these are at least workers having a visa, having a work permit. What I've not really talked about until now is the elephant in the room. What happens to undocumented workers? Undocumented workers in many parts of urban Asia are a substantial part of the underground economy which keep costs down. I haven't seen any literature, really, speaking about undocumented migrant workers in Asia. Everybody talks about Mexicans in the US. What about Asia? There's absolutely nothing. So they do the same thing. They talk to their friendly doctor from the neighborhood who takes an extra real in order to present them some extra medicines. So what happens to them? So everything is an emergency. They are product of emergencies. Undocumented workers or even migrant workers are products of emergencies. So what are the solutions? The solution is, as a few healthcare economists are sitting here, why don't we have better economic analysis of what migrant workers bring on board to a regional economy. What is this cost in dollars and cents? What is this cost in dollars and cents? What does a migrant worker bring on board? Please integrate them within public healthcare systems. They're outsiders, yes, but they live in your country for 10 years, 15 years, 20 years. So are they really extremely short-time period people? No. And also create a market for the private sector in order to bring them solutions. Why can't there be insurance solutions from the private sector for these millions of workers? Okay, I've spoken enough. Thanks.
Thank you very much, Mr. Prasad. Thank you, Dr. Awad, Dr. Mataria, for painting the big picture and really showing us what it means, and Mr. Prasad for showing us what it means, the human cost to the individual of the policies and things we're talking about. And now we will open it up for questions. So please. And Dr. Sultan Barakat will start.
First, I'd like to thank Marwa for stepping in. Talking about conflict is exactly what we think should happen with interdisciplinary joint thinking. And for me, what was described towards the end in terms of the migrants' reality is actually becoming quite a lot of people realities in our region, not just in terms of migrants workers, but refugees and displaced populations. As a Muslim world, we now account to roughly 70% of refugees around the world, and maybe equal percentage of conflicts and so on, but we don't have the systems to cope with it. And what struck me earlier on with Awad's presentation, when we talk about state fragility, it is an increasing phenomena in our region. And in fact, it's more than fragility. We have total state collapse in lots of areas, which really brings into question the whole idea of a national health system or a global coverage anymore. We're really talking about a community level solutions. If you look how communities are managing in Syria today at the level of small municipalities, even tribal in parts of Yemen, how do these people cope? How do they fit into the bigger health picture? And at the same time, we have an increasing phenomena of cross-border linkages and people relying on services across the border. So, for example, cancer treatment, people come from Syria specifically to Jordan to get that treatment and they go back and so on. So it's becoming a very complex picture, and one thing, if anything we get out of this, is really we should do more in focusing on issues of conflict in its totality, because in our region it's become part of our reality. We can't escape it. We can't pretend and hide behind the bigger statistical picture of the whole region. The reality is that a lot of the population in this region is really trapped in the consequences of conflict. So I don't really have a question as such. I just wanted to make this remark because it's been very inspiring listening to your presentations. But if I must ask something, would be what can WHO do more in that direction in terms of setting the scene in doing more research in this area? And are you collaborating with Undp at all? I mean, they're just about to put the next Arab development report. And it would be very interesting, I think, to look at the cost in terms of health and its consequences on the development goals.
Hello, Dr. Mataria. Would you like to answer that one now? Okay.
Okay, thank you very much, Prasad, for the reflections and for the questions. I think I totally agree with you with the question of legitimacy and the question of what states could do and what alternatives are there. So, you know, I mentioned I come from Palestine, and in such a context, when we were under occupation until now, until it still didn't end, but at certain point in time, when people had to find alternative solutions to provide for the needed services in the absence of the state, then this is when community became really important. When the civil society organizations, what we call non-governmental organizations, have really played a role in substituting for the functions of the government, and when solidarity between the members of the community has really played major role. I lived that, and I have memories of how things relying on neighbors and working with smaller communities in order to be able to sustain and to survive these difficult circumstances. We have been, in some of the pieces of work that we ran, is to call for something that we would like to qualify as universal health coverage beyond borders. This is when you can start thinking about people mobility across borders, and then you see how you can guarantee the access and the financial protection of the individual when that person moves from one place to the other. It can be linked to conflict and refugees, displaced populations, but also it can be linked to migrant workers, to labor migration in a certain way. So for people coming from Far East to the Gulf countries and then working here, so how would they be covered while they are here? How that coverage could continue once they go back? So to think about something that is across borders, that is more, that goes beyond the boundaries of a certain nation. But we have also identified some directions for health systems, how to function in these circumstances. I think we have, from health system point of view, I'm taking my hat as a health financing person, we need to distinguish between delivery, service delivery, and financing. For service delivery, our message has been to integrate the delivery of services for the refugees, for the displaced population within the national system, so that there is no parallel system that would be created. We need them to be part of the national system. But for financing, there might be alternative channels, because you cannot assume that the recipient country would be also bearing the cost of care for the refugees, for the migrant population. So you might have a parallel financing channel that continues to interact with the national delivery system so that it can deliver for them. So that's where one can think of establishment of equity funds. You were talking about multi-donor trust fund for that matter. Now, what WHO can do, and I can also invite Dr. Mirza to reflect on that. So we have now finalized and started implementing what we call the Global Program of Work. It is the 13th version, so it's our strategic document of what WHO could do in countries. And when we say WHO, we are the member states and we are the secretariat, so we are all one together. And something that the Global Program of Work, the new one, has brought in is that we need to tailor the way that we work with countries. And it has identified 4 approaches, sort of, for WHO's intervention in countries, going from substitution in certain instances where WHO can act as a service delivery agent in the country where the facilities are not there, so you can go into the service delivery, to a situation where you need to build the foundations of the system, so the basics of a health system, or to build institutions, or to look at how to transform the whole health system that is there. So like in the Gulf countries, our work is mainly on transformation agendas in Saudi Arabia, in Oman. They had the Vision 2050 with Qatar. I mean, I have been working closely with colleagues. Somebody mentioned that they are from the Ministry of Public Health on the idea of establishing a health insurance corporation, but also with the separation, Hamad Medical Corporation and others. So that transformation agenda. So we look at it as going from substitution to foundation to institution to transformation, and to tailor our support to the country based on the level of development in the specific area. Now, with regard to your question about UNDP and other UN agencies, so we work closely together. There are inter-UN agencies platforms where we work. I'm involved in one related to financial protection and social protection. We had just had our meeting recently, and we are developing some guidance document on how to think social protection, health protection being part of it. And it is usually managed and facilitated by Undp colleagues because they have usually the upper agenda of UN involvement in the country. So this is what I can say about this, and maybe if there's
like
opportunity,
to
maybe Dr. Mirza can reflect further.
No.
Sorry, I'm bringing. He always has a lot to say.
You're
So.
putting him on the spot. Okay.
Thank you very much. Thank you for inviting me. First of all, let me begin by saying that how pleased I am to be here this evening among friends, and this is 124th seminar, Global Health History Seminar Series, and I had a pleasure to attend many of them. And I'm a old-time friend of Global Health History Seminar Series, so very pleased to be here. Secondly, I'm also very feel privileged to be here because the topics that we are discussing are the heart of the problems in the region right now. And to be very honest with you, I was not very familiar with the center that you are running on conflict and humanitarian studies. I think that's exactly what is needed in the region right now. With this, I would also like to mention, because I will not have time to discuss with especially Dr. Sultan, that we have a new regional director now in WHO Regional Office for Eastern Mediterranean, and he is very committed and passionate about promoting the idea of using health as a bridge to peace. And the number of conflicts and so many different forms of conflicts that exist in the region, he has given a call for solidarity and for action, and he has actually challenged us to engage with all possible actors and all possible institutions and intelligentsia in the region to develop this notion of health as a bridge to peace. Now, and what I'm by mentioning this, and why I'm mentioning this, is that these are the kind of centers and these are the kind of institutions where we need to engage. And we would be very interested to explore further this idea with the center and to develop a body of work which is helpful, which is empirical, which is reality based, and use that as a possible means of promoting this idea. Now, one thing which I would also like to say is that WHO itself is changing, like everything else. We have a new leadership now, even in headquarters. We have first African Director General, Dr. Tedros, who has given a new mission to WHO. And the mission is very straightforward: promote health, keep the world safe, and serve the vulnerable. This is very simple without being simplistic mission, which we are all now part of, and we are promoting it. One thing which I would like to say at the end is that I'm really moved by Dr. Prasad and the way he has shared his insights, which are very, lived through insights. These are not just a very, superficial talk about these issues. We all know that there is a migration and there are issues and undocumented labor, and I have a comment and a question on this. My comment is that absolutely I agree with you. Emergencies are not just aeroplanes throwing bombs. Emergencies, there are 50 shades of emergencies, and it is very difficult to put them in a watertight compartments. And we need to understand that, and we need to have that mindfulness about the existence of emergencies in so many different forms and shapes in the region and do something about it. My question to you is that because you have a very close eye on this issue of migration, do you think that over the years, and especially over the last 10 years, there is a positive trend towards migrants in the region in terms of especially and specifically with reference to their health care? Because our counterparts are ministries of health and ministers of health in WHO, and when we speak with them, we have been raising these issues. Informal sector, their issues, and especially with reference to healthcare, we have been raising these issues. It's not that we are blind to it. But the answers that we get increasingly is that we are now expanding our healthcare coverage to migrants, increasingly so. And we are developing special schemes for migrants. Few I know, but generally, when you look at this problem, are we on a positive trajectory, or we are stable? It's a status quo, or we are going down? And I would really like to take up this from this discussion today, that how we can actually join hands also to raise these issues and bring them into the attention of the political decision makers. Thank you very much.
Thank you very much, Dr. Mirza. And I would like to take one more question from Dr. Yusuf Dawood. And then we can answer these two questions. Okay. After Dr. Yusuf, okay. And then we can answer all three questions together.
Thank you, distinguished speakers. I couldn't help but notice that there is some emphasis on expanding healthcare services, but with the presence of budget deficits and national debt and institutions like the IMF on countries' backs telling them to cut down on spending, this will be much more challenging to do. Wouldn't it be also very effective in designing policies that increase the efficiency of healthcare provision, meaning doing it at a lower cost, so that it will be compatible with more budget deficits and more national debt?
Thank you very much, Dr. Dawood. Yes, please, in the back.
My question is from Dr. Awad Mataria. It's about exactly about the polio, which is an infectious and communicable disease. It's almost eradicated in the whole world, but few countries, namely Nigeria, Afghanistan, and Pakistan, still have cases of polio. Does WHO is working on this? And also, it's related to the migrants as well, because if migrants does not get the vaccination, it will be spread in the whole world, and the eradication or the development that we have will be nullified. It will be itself an emergency. Thank you.
Thank you very much. Dr. Hanan will have the next question.
Thank you. I actually have two questions.
Okay.
So the first is to follow up on something that Awad said about building resilience in communities. And as much as I used to like resilience, I'm actually now very wary of it.
Yeah.
Because I think over time, it's become a way to let governments off the hook.
Yeah,
So we build resilience of communities, we build resilience of neighborhoods, et cetera, and then no one has to worry about them because they're resilient. Yeah. So I guess my question is one, in those cases of emergency, how do we build resilience indeed without getting anyone off the hook and making sure that people are, or governments specifically, are still carrying their responsibilities? So that's one question. The other really has to do with the values of universal healthcare coverage. So we talk about efficiency, and we talk about, you know, who can possibly finance and provide this care and so on. But what I'm seeing that in our region, unfortunately, every emergency is starting as acute, and then it goes on for a very long time. It actually becomes the reality. And so what starts out as emergency healthcare provision, whether it's by UNRWA or by other WHO organizations or other international aid organizations, somehow then over time gels into a permanent type of healthcare provision. And one of the things that we don't talk about as much is how do we, in that process, make sure that whether it's refugees or IDPs or whatever, that we're not just talking about paying for their healthcare services, but also about values like choice and dignity and so on. So we never put money in their hands, so they have no choice in the types of services that they receive. They have no choice even in the food that they purchase.
True.
Right? So my question is it even possible, or is this just a romantic dream that we can, along the way, also make sure that we're not sacrificing essential values?
Thank you very much, Dr. Hanan. So I have 3 more questions, but I'm wondering if we should answer these questions first and then move to the next 3 questions. So Mr. Prasad can answer the first question. Yes, please.
Actually, regarding the approaches for migrant workers and social protection, my observation and my analysis has been that thanks to a lot of media attention on migrant work, healthcare, and safety-related accidents which happen on mega infrastructure projects in different parts of the world, healthcare for migrant workers has been emergency healthcare, which means they fall off height, they injure themselves. So what is the compensation? Which hospital they are taken care to? Who pays for the operation? And how fast he can be deported back? Well, the conversation regarding migrant workers and health is very, very restricted to when and how is the accident happening. We need to detach the entire value system and framing regarding migrant workers from being just a bachelor body who is basically hung off a harness, honestly speaking. When a migrant worker comes into the equation in a labor camp, in a construction camp, in a dormitory in Singapore or in Kuala Lumpur or in Johor Bahru, health has to be treated not as an accident. The media discourse, whether you take the liberal media in the West or you take very Singaporean Straits Times, and by the way, Straits Times has a migrant worker beat nowadays, because migrant workers have been turned into the new subaltern, because they need to celebrate something, so they're celebrating migrant workers. So linking what Dr. Mirza just said and to your thing about values and dignity, when we speak about values and dignity, when we apply this lens to the migrant worker populations, which are millions, honestly speaking, they are not 1 or 2, they're basically treated as an object for condensation and extreme pity. So on one end of the spectrum, we treat them as biopolitics, and we treat them in a very Foucauldian way that they are just bachelor bodies. But on the other end of the spectrum, when we speak with human rights NGOs and activists and people who fly in from London and New York, basically, and they bring in this values conversation. Yeah. What is this values conversation? This values conversation is a very slippery slope. So the conversation has to be managed between an accident and a slippery slope. Thanks.
Thank you, Mr. Prasad. And Dr. Mataria, I would really ask you to be brief, because we have 3 more questions here, and we would really like to get to them as well.
Thank you very much. Thank you for all the questions. I'll be happy to discuss them further, but I'll try to provide some elements of answers to the 3 questions briefly. So the first one with regard to Dr. Youssef, with regard to the having budget cuts, and at the same time we want to go for universal health coverage. I think universal health coverage is coming with an idea and a vision of aspiration, but also realism. So it's not about providing everything for everyone at zero cost. What universal health coverage is trying to bring to the nation, to the countries, is to try to start by defining what are your priorities. What are your priority needs, and what are the priority services that you want to deliver and to make sure that everyone has access for. That's why in our work we have brought in this idea of defining a priority benefit package, that this is what a country can afford at that stage. And once resources can be made available, would become available, you can expand that coverage. In the literature, this is sometimes known as progressive universalism. So to start something, but guarantee that everyone has access to it, and then you can go deeper. Of course, efficiency is very important. We talk about having more money for health, talk about financial protection, but we also talk about having more health for the money. And in the World Health Report 2010, we identified 10 areas of inefficiencies, of wastages that are happening, and we work with countries on how to enhance those. We estimate that 20 to 40% of what is being spent on health is being wasted because for a reason or another. And that efficiency is very important. So when we go and talk with ministers of finance, they always raise that issue. Be efficient and then come and ask for more money. So if we show that we are becoming more efficient, then we can ask for more money. And that's why the agenda, all our work on the strategic purchasing is inspired by this agenda. Resilience, this is a very tricky question, Dr. Abdul Rahim. So Hanan is one of the people who wrote about resilience maybe before that concept is taken up globally and being used. So what we are talking about now is more of resilient health systems. So it's different than the resilient populations. And want our health system to be resilient enough to face the challenges, to face the emergencies, the crises, and at the same time to adapt them, to cope with them, and to become stronger in the future. But it is by no means to say that it is not the responsibility of the governments, that countries, people have to be resilient so that the governments are released from their responsibility. I like your view about the responsiveness and the value of, well, you didn't call it responsiveness, I'm bringing in that now. The idea of having also taking care of the preferences of the population. I wanted to link it with the responsiveness goal of the health system. So we say health systems have three goals: improving health, responsiveness to respond to non-medical needs, and financial protection. Maybe in the framework, this is something that needs to be brought up more strongly.
It's clear.
And with regard to polio, so now we have only two countries, Afghanistan and Pakistan. Nigeria has eliminated it. I think they are at the stage of eradicating it after a few years. And we are working with them more intensively. I mean, maybe Sanjoy can shed more light on this. But we are working, we have a huge program of work on polio eradication. And it is something that at the heart of our agenda of work at WHO. And some countries, it absorbs most of the resources that WHO brings, but Sanjoy can...
I mean, it's a classic case of health workers working in conflict situations in Pakistan and Afghanistan. These are the real public health heroes. These are the voices that need to be recorded, because there are lessons of how they are, navigating very complex politics that should not get lost. But this is, I mean, Sultan is not here, but this is a classic case of how do you deploy resources, scarce resources, in very difficult, conflict-ridden societies. So I think Nigeria is in the certification stage, whereas, yes, so inshallah.
Thank you very much, Professor Bhattacharya and Professor. Okay, we have 4 more questions. Okay, so I'll start with the people who raised their hands first. So here.
Thank you very much, Dr. Marwa. In this fascinating 2 presentations that I have heard today, I feel, I'm not sure, but I'm just asking whether there is any framework between the issues of health and issues of migration, because in many kind of, basically global frameworks, sometimes there are certain issues which are not really put together or put forward, basically. And at the sometimes there is as well a fragmentation, basically, when issues of migration are discussed, maybe discussed at the legal level, than the other human rights kind of basic human rights level. So just to, I mean, basically to understand if there is anything going on between IOM and WHO, that would be very interesting to know.
Thank you. Okay. Fatma, next. Oh, 5 more questions. Okay. Fatma El Abrahim, please.
Yeah, actually, my question is about mental health. What the WHO does for providing like mental health care for refugees, because when we think about health, some people think about just the physical health. So, what is in terms of mental health?
Thank you.
Yeah, thank you.
Okay, here.
Okay, thank you so much for the panel. I think part of my question already been addressed by Mr. Awad, because it's actually coming from the ground. I worked in Libya, in Sudan, and the dialogue around how the investment in emergency can actually accommodate the developmental agenda, which is actually for us was like very difficult, how we can use the evidence in planning for more impact and better results.
Mm-hmm.
So my question here, do we have a model, a real model, after this very long period of emergencies in the region, actually translating this good idea in reality? The other thing that, and I like really the point that emergency is not because of conflicts only.
Yes.
Emergency can come from the deprivation itself, deprivation because of poverty, accessibility to the, so it's like a circle. How the social policy can actually accommodate this need to break this circle, so we can have like a better health systems, better health services, and then better performance of the health related indicators. Because actually in some countries like Sudan as example, for more than 12 years implementation of emergency, then the health indicators was like the lowest.
Yeah.
After all these investments. So still the questions are there, and the research is need to actually extract what is the reasons behind this.
Thank you.
Thank you so much.
Thank you very much. So we have Amal, and then I guess last question. So.
Thank you so much. This was amazing. And I have one comment and I have a question. So my question is to the panelists about health inequities. So for example, the migrants or the migrant workers, undocumented workers, this is one layer of inequities, but also in emergency situations, whether acute or chronic, we also have even more layers. And it's not just about protecting people from what is called catastrophic expenditure, but also protecting them from being from being exploited, especially for women and children. And we know this from the many refugee camps that exist, whether in African countries, whether in our countries, in Arab countries, that women and children become the most vulnerable. But also, if you're a woman with a disability or a mental health problem, you're even more vulnerable than the other women around you. So how is that protection given? Because it's not just enough to give universal health care. And I don't believe at this point that we are capable of reaching that point in emergency situations. But the basic packages, they could be life-saving. But then there's this, so the first layer of inequity is who is covered. And then when donors come with their agendas and the donors say, we're only covering people with HIV/AIDS, and then the people who don't have HIV/AIDS don't get health coverage. And in some countries, people, and this is testimony of some doctors that I used to study with, some people do willingly go and try to get infected with HIV/AIDS so they can get health insurance, so they can get health coverage for them and for their children. Women tend to get more pregnant than they want just because they know that if I'm pregnant, I will be covered. So what do we do regarding these layers of inequities, whether in emergency or non-emergency situations? And my other comment is about health for peace, because I've been involved in a few projects regarding that area. And from my experience, and maybe it's not that professional, it's not that profound, peace is more political than we might want to think. And trying to build the bridges between the healthcare workers, it helps, but it helps to only some extent. It doesn't really make that huge of a difference. I'm sad to say this, because I really wanted to see those projects work. I'm still an advisor for one of those projects as well, back home in Palestine. And mostly we link the nurses together for the referral purposes, but also for translating and exchanging patient information and records. But it doesn't really bring us any closer to peace, I'm afraid to say. It's just a way to say that we are doing something. It's a way to bond as human beings, but when a war breaks out, it's like my nurse could go to the army and wear her uniform, and she will stop seeing me as a human being. And that's one layer of the problem. So we can talk more about this if you like. I'm very concerned about this, and I want to see hope in that area, because it's my passion, it's my life. But yeah, it's not working that greatly.
Thank you very much, Amal. Our last question here.
So thank you, panelists, for this nice presentations. And my question to Dr. Awad Mataria, it's about the framework you are right now developing. So you have three goals or three outcomes. So I can see quality. You say full coverage. You say equity. I don't remember the third one. But where is quality and safety of the care? You know, universal health coverage without the quality and safety of service mean nothing. And how is this linked or can be linked to the work right now going on by EMRO in relation to addressing the quality and safety of service in the emergent situation led by Dr. Mander and Professor Sheila Leatherman? Thank you.
Thank you very much. So we have a long list of questions.
Okay, I'll try to be brief, and hopefully while giving the value to the questions that have been raised, which are all great. So first, with regard to the linkage between health and migration, so there have been two global compacts recently coming out from the UN level. So one is on global compact on migration, and there's a global compact on refugees. And what we had observed is that health is not sufficiently present in these compacts, especially the one on refugees. Refugees, there was a bit, but not in the one on migration, I should say. So that's why WHO has worked on developing a strategic document on health of migrants and health of refugees. And I mentioned briefly, we had a recent inter-regional meeting between us and the European Euro office, our colleagues in Europe, to look at developing a regional framework for action on promoting health of migrants and displaced populations, where we are trying to bring in health more strongly into them. So that's the framework within which we are working. With regard to mental health, yes, fully agree. So mental health, and also it's not only about medicalization or medicalizing the mental health concerns. Our work on mental health has been primarily driven by the idea of integrating mental health in primary health care. And when you do that effectively, then you can start taking care of people's mental health beside their physical health in a more efficient and concrete manner. I very much like the idea, I didn't know the name, but somebody mentioned the linkage between emergency and then development. And so the way that we are, yes, in Libya, yeah. So the way that we have been now presenting it is to not to disconnect the two, and to make it more integral to the other, so that what you do in a humanitarian setting does not result in a negative, in a harmful impact when development comes. And on the contrary, we would like to start thinking development at the same time as we are trying to address humanitarian action. And that's why we came up with this framework that is called the Humanitarian Development Peace Nexus. The idea of that is to think development along the side with the humanitarian action. And this came up from the there has been a summit in Istanbul in 2015, I think, it's called the Global Humanitarian Summit, and we have the Global Development Agenda. So how to bring in the two together, thinking development and the humanitarian action. The question about inequities is really very, very, very important. I mean, universal health coverage is coming to help realizing the goal of the right to health, and it wants to bring it in an operational point of view. So, and for me, I don't know if not everyone would agree with what I would say, but when we look at what was mentioned in Alma-Ata in 1978, when primary healthcare was introduced, it was a lot of promises, and it didn't come with the instruments to make it happen on the ground. Now we have the Astana Declaration, 40 years after Alma-Ata. It came out, a declaration that was announced in October last year, where we are trying to bring in more of components of primary health care, which are more operational in a way, including the fact of how to look at universal health coverage. So in our work, now we are also trying to bring in the question of the right to health more prominently, and to see how we can operationalize this notion of right to health. So we work with political philosophers to try to bring in how to think about the right to health. We had a recent, very nostalgic speech recently in one of our courses on that. I mean, it is strange when you think of it, because we talk universal health coverage is about everyone. The fact when you say it is everyone, one would assume that it is equitable in a way, but it doesn't happen automatically. When countries, talking about health financing, my area of focus, when countries try to expand coverage and say who is covered, who is not covered, we try to insure them and to say who will be insured next. And it has been evident that if you start thinking of that, then you will insure a certain population who would start having certain benefits and certain interests that might block the system from expanding to others. Countries that have used this pathway of expanding population coverage took them 30, 40, and 50 years to reach the full population coverage. Our message now is cover everyone from day one, but maybe for a limited package, and then you keep deepening it. This is what I qualified as the progressive universalism. But we have a document that was published in 2011 called Fair Choices on the Path to Universal Health Coverage, which tries to come up with strong messages, like it's unfair to deepen the coverage of those who's covered before reaching full population coverage. It's unfair to focus on the formal sector before covering the vulnerable. Right? So such messages that came from philosophers, from ethicists, and others. The last point about equality, I mean, without equality, you cannot call it universal health coverage. Sometimes I feel it even, sometimes people want to call it quality universal health coverage. I say this is wrong, because if quality is not there, then it's not universal health coverage to start with. And you have rightly referred to the recent consultation we had to identify indicators to look at qualities in context of emergencies, and we have that at the heart of what we are doing in the region. So with this, thank you very much for your question.
Thank you very much. And Mr. Prasad, would you like to add anything?
Well, only one point about health inequities and the social context in which it is applied. Public health is basically thought of as outcomes, but at least regarding migrant workers and basically internally displaced people as well in India. India has a humongous population which moves from one end of the country to the other. Same thing in China. Same thing in many, many big countries. What really happens is, since the public health infrastructure in most countries is inadequate, for better or for worse, it's inadequate. So I have only 2 points. Regarding migrant workers and how they are actually cared for in the real ground level, if you ask me, more help is provided by the masjids and the churches, and basically the Indian and Pakistani and Bangladeshi associations, than actually it's provided by the formal healthcare system. So if no, but I'm talking on a broader context.
Yes. Qatar is a unique case, actually.
Yeah, I'm talking about a broader context regarding migrant workers in Southeast Asia and also in this part of the world. Doha is rich, it's very progressive, and it does very, very well. But when we talk on migrant workers and how healthcare is actually treated, most migrant workers actually head to the doctor in the local association rather than the formal healthcare system. And one more thing is very important is the private sector has to play a bigger role and acknowledge the migrant workers as a client base. Once that happens, I think so a lot of energy can be unleashed. Thank you.
Thank you very much. Thank you very much, our distinguished speakers. And I would like to thank also Maisa Abu Hlel, who was instrumental in organizing the talk and the seminar. And of course, Dr. Sultan Barakat and Professor Bhattacharya. So thank you very much. And please join me in thanking the speakers and everyone who helped make this event happen. Thank you very much.